My name is Jennie Bergen, and I am presenting to you today Sexual Assault in Women, Trauma-Informed Care. So I just wanted to let you know who I am first before I get started. I am an assistant professor in the University System of Georgia, and I teach nursing, and I'm also a sexual assault nurse examiner, and we call ourselves SANES, and we have specific training to take care of females, women, children, adults of all ages and groups in sexual assault. And we have specific training, and I'm going to share a little bit about that with you today. So let's get started. First, I want to let you know what the objectives are so you know what I'm covering. Since we are talking about sexual assault, I wanted to spend just a few minutes talking about what sexual assault is and define it, because it can be complicated. I'm going to uncover some statistical data, not a lot of data, but some major data. I'm going to describe the female victims that are victims of sexual assault. And we're going to identify who the perpetrators are. We're also going to talk about Georgia's response to the victims of sexual assault in our state. We're going to consider the negative impact that sexual assault has on women. And we're going to discuss trauma-informed care and what that looks like and how we can all be a part of that, so we can better keep our patients, our community safe, and that's going to be trauma-informed care. So the first thing I want to talk about is what sexual assault is. And it's interesting that we have such a low report statistics for women who are sexually assaulted. And one of the reasons why, there's a low reporting is because they're not sure that it was sexual assault. And so getting informed about what sexual assault is really important for all of us who take care of patients, the patients in our community. So sexual assault is defined as penetration of any orifice of the body, and it can be penetration not just with a body part, but an object as well. It's also attempted penetration of any orifice. It's inappropriate touching, also unwanted touching. It involves incest or child molestation, voyeurism, indecent exposure, sexual harassment. And it also includes when the victim is unable to give consent. So all of these definitions are thought of as sexual assault. That's why we don't call it necessarily just rape. It's called sexual assault because it has such a vast definition. To talk a little bit about the statistics for women, it's amazing to me when I look at these statistics that when we're talking about sexual assault, 91% of our sexual assault victims are women. And that's why we're focusing on women today. Over half of the women in the United States have expressed that they have experienced some sexual violence, and I find that incredible. 1 in 4 women have experienced completed or attempted rape, which was defined as the penetration or attempted penetration. So that's just an unbelievable number. And it's definitely bringing attention to how we need to take care of this population. So who are our victims? Who are these women that are sexually assaulted? I have had an opportunity to look at a lot of studies. I read and I keep up with sexual assault journals and the community. And I have to say that when we're talking about American Indians, we're talking about an enormous community that are victims of sexual assault. I remember when I went through the training that I was mentioning to you earlier, the sexual assault nurse examiner training, my instructor or our instructor functioned and was a sexual assault nurse examiner in a state with a high number of American Indians. And so all of her photos were of American Indians, and she wanted to make sure we were aware that American Indians are the large portion of sexual assault victims. So American Indians, although they're only 2.5% of our population, they are 34.1% of the total of sexually assaulted victims, whereas white individuals 17.7%, Black 18.8%, Asian Pacific Islander is 6.8%, and then of course we're going to have high mixed because we're not all just one or the other. Mixed 24.4%. So not only are, I just wanted to say this too, to add to the American Indian Alaskan community, is that not only are they victims of sexual assault, but they also have high victimization towards murder and other types of assault. And they also are one of the very few groups that are more likely to be sexually assaulted by an individual that's not within their community, their race, their culture. So I'm throwing out some statistics, and I know that we are in Georgia, and we are the Georgia, we're talking about the Georgia Commission about women. And so how does Georgia compare to the rest of the United States? So we talked about some big numbers earlier in the other slides. I was glad to see that our state is a light color. So the numbers here in our state are the numbers of sexual assaults per year per 100,000. This was one given year, recent year. So if you look at our number, we have 27.5. We're a pale color, which I'm very happy about. And it seems like you cannot ignore Alaska over there in the corner at 148.7 per 100,000 annually of sexual assaults. There are also some other extreme cases, such as Michigan, Arkansas, some of the midsection. But for the most part, we're going to focus on Georgia. But before we move on, talking about Georgia, I think it's good to see this where, we're probably, in the lower numbers compared and doing a pretty good job, hopefully, in taking care of our victims. So we talked a little bit about the victims. So who are the perpetrators? Not surprisingly, 99% of the perpetrators for sexual assault are men, and they are most of the time known by the victim. Yes, we have strangers, sexual assaults. It does happen, it occurs, but it's more likely going to be an ex-partner than it is going to be a stranger. And for these perpetrators, who they are is the primary reason that a lot of women don't disclose. And we're going to talk about that in just a minute. But only 2% of these perpetrators are actually going to spend time in jail. And I think as a state, we're working on that. We're working on justice for our population. So hopefully that number will go up and we can have more accountability and justice for our victims. I mentioned this about the disclosure, but when you see it in this graph, in these colors, it really hits hard. When you see that of sexual assaults, only 28% are reported. So although we have high numbers in the United States and we saw some of the statistics, we have to have that reality check that those aren't really accurate numbers. Those are the reported numbers. And so when you look at the statistics and you think 1 out of every 4 women have, et cetera, then we think, well, it's got to be a larger number. And so this is such a large problem in our community. If we've got 72% of sexually assaulted women that aren't reporting, what can we do to change that? So there are significant reasons and legitimate reasons why women don't report this 72%. So as a sexual assault nurse examiner, I work in the Southern Crescent Sexual Assault and Child Advocacy Center in Hampton. And I many times am on call and I get called in, and then I get there and the advocate says that the patient declined to report it or does not want to come to the center. And And sometimes they give a reason, sometimes they don't. But here are some of the reasons why they would back out of reporting or they would back out of coming to the clinic. And I was looking at a recent study that showed that self-blame is actually a little bit higher than we've always thought that it was. We've always thought it was the retaliation from the perpetrator, but self-blame is kind of going up on the scale a little bit. And I'm a little bit surprised that we're so hard on ourselves as women that we're going to say, well, what was I wearing? Did I put myself in that situation to go on that online date? Was I out after midnight? All of these things circulate through these patients' minds, and they think, well, maybe I'm part of this. Maybe it wasn't really their fault. And I don't want them to get in trouble if it's something that was my fault. And so self-blame is something that there's a lot of room for education for our patients. These patients, they fear a negative social reaction. So they're afraid that their friends, their family, they're going to find out, and then they'll be stigmatized. They'll have this stigma on them that when someone, oh, that's the girl that was sexually assaulted. And nobody wants that stigma. So that's really a big point in this presentation, is for us to figure out how we can be a more forgiving community to where, we can help, not stigmatize. We may not be the people that are stigmatizing, but we can help a community to try to prevent the stigma. So if the assailant, and we said the assailant a lot of times is known to the victim, sometimes I use assailant and perpetrator back to hand in hand. They're a little different between the two, but sometimes I'll use the same word. They're afraid of retaliation. So many times the patients that I've taken care of, they will express that they had a weapon used in the situation, or they were threatened harm. And so even so, some of them will still come to the center. They'll still report, which is bold, but we're glad for it. Women are afraid of not being believed. I see this a lot in the field, and sometimes the patient will actually turn to me and say, well, you believe me, right? And of course I do, because it's not my job to believe or to not believe. My job is to support the patient, make the patient feel less traumatized. We don't want patients coming for help and then feeling like they're re-traumatized. So of course I am not going to have a patient feel as if, or make a patient feel as if she's not being believed by me. We have to start there and receive our patients really well. Patients want to keep their private situations private. It's understandable, but we also want our patients, our victims, to get help. Sometimes these patients are in a non-disclosed relationship, and they're afraid that if they report, that everyone's going to find out they were having this relationship. And you could just let your mind go crazy about what kind of relationships we're talking here. But it's a relationship that the patient doesn't want other people to know they're in. So if it's a non-disclosed relationship, it's a bold move to report and to say you were sexually assaulted by someone that you're having this relationship with. I mentioned that they don't want their friends and family to find out many times. And sometimes they don't think of it as sexual assault. That's why I wanted to go over those definitions in that first slide, because they don't think that some things, well, he just did this or he just did that. And to me, you've got to take out the just. The just minimizes it. So, take out the just and let's talk about what happened. And they feel shameful. Sometimes they're so ashamed, they're just embarrassed. And that brings up a thought that I had many times when the patients come into the sexual assault center. We're going to talk about what that center looks like in just a minute. But they'll just come literally shaking and just nervous and crying and tearful. And you can literally see their body shaking. They're so afraid. And by the time the exam is underway and then we're at the end of it, many times they'll actually ask me for a hug. And so we're doing something right. We're starting off this trauma-informed care from the very beginning. If we don't use trauma-informed care for our patients, and we make mistakes that are impactful, and even if we do trauma-informed care, we have to realize, as part of trauma-informed care, that there's going to be a broad range of mental health problems after a sexual assault. And honestly, after any trauma, there's a potential for these mental health problems. But with sexual assault, we're discussing how we can minimize this happening to our patients so we can keep our patients safe. Not safe just environmentally safe, but mentally and emotionally safe as well. These patients will oftentimes experience many of these all together, not just one separately. Anxiety, depression, substance misuse, PTSD, and suicidality. And these are significant mental health impacts that we hope that we can, in some way, help to prevent from rearing its ugly head for these victims. Okay. I want to just mention, we talked about reporting, and I'm throwing out the word reporting as if you're supposed to know what that means. Reporting is when a patient discloses to someone that of law enforcement or so forth of the incident. The most common form of reporting is for the victim to call 911. A victim can also call the police. And if that happens, then the police is dispatched. And we're going to talk about our SART, our sexual assault response team, in just a minute, but police and law enforcement are a part of the team to help with trauma-informed care. And so the police officer will call the clinic, whichever clinic that's in that county, and offer sexual assault services for the patient. The patient will talk on the phone with the advocate and decide what the next steps are. Patients can also call crisis hotlines. We have a national hotline, we have state hotlines, we have lots of hotlines. They could actually go to a hospital or clinic, and in the clinic, they will have options to get police involved or not. I just wanted to highlight that not all victims want police involved. So they may want to come to the center and get the care that they need, but they don't want to file any kind of report. And they have that option to do that. So if they want to call the police, then the police can be dispatched and that process continues. If they don't want to call the police, they have the option from the medical clinic to call the clinics and actually talk to a sexual assault nurse or an advocate and decide what next steps are. So they have about a year, I think they have 1 year from getting the sexual assault examination to change their mind and to actually report. So they may not know what they want to do at the moment. So they'll go ahead and go to the clinic, get the care that they need, and then they have a year to decide if they want to take a step further and notify law enforcement. So how is Georgia responding to us having victims, so many victims a year in our state? How are we responding? I'm going to talk about the CJCC, the Criminal Justice Coordinating Council, is such an important organization in Georgia. Although sexual assault response has been happening for years, and CJCC, I think, was started in, I could be wrong, give or take, I think it was 1981. But recently, in 2015, they developed a sexual assault response team, and we call those SARTs. And that was created by the CJCC. And their goal from that was to create a unified, consistent, comprehensive, and compassionate approach in how we, as Georgia's criminal justice professionals, respond to crimes of sexual violence in our community. And they're working very hard. In 2016, Georgia passed a law that required police officers to submit rape kits. For some unknown reason, rape kits were piling up at law enforcement precincts, and this law said you have to release these kits and get them to the GBI. Grant money was provided for these kits to be processed because in 2017, by August, when the kits had been released, they had over 2,000 kits that had to be processed, and it had to be people to process those kits. And what was interesting is when they were looking at these, did the DNA from these kits, one right after the other, they identified repeat offenders. So because they weren't processing the kits timely and there was no justice for some of these perpetrators, and they would keep reoffending. So that I thought that was super interesting. In Georgia, we have 32 sexual assault centers across our state, and we also have crisis lines across the state. When I'm thinking about 32 sexual assault centers, I'm thinking, well, is that good or is that bad? Do we have 30, other states have 40 and we only have 32, or do other states have 10 and we have 32? Where do we fall? So I read that there are about 1,100 sexual assault centers across the United States. So if you divide that by 50, that would be an average of 22. So we're probably an average size state. So I would say we have 32. So if you divide it by 50, I realize states like Texas is bigger, Rhode Island smaller, but I think we're doing pretty well to have 32 sexual assault centers across Georgia. And these centers practice trauma-informed care for our victims and sexual assault victims in Georgia. And I just threw this together. I thought, let's just see where these clinics are. As you can see, the Atlanta area, we have a little bit more plentiful, but of course there's more population in that area. You can see where there's some gaps and where we might have some needs in our state. But for the most part, I think we're pretty spread out. We're not all in the north, we're not all in the south, we're not all in the middle. It's pretty spread out with a few little gaps here and there. And so I talked about the CJCC forming the SART team, sexual assault response team. And this is a little bit about what that looks like. So to initiate a trauma-informed care, we have to all be on the same page. The sexual assault nurse examiners like me just can't be functioning independently. Advocates can't be just functioning independently. Law enforcement functioning independently. We're all working together and communicating together to make sure that the patient is taken care of properly. So law enforcement, they're trained on the criminal justice issues and the local ordinances. And we're constantly communicating with law enforcement. We have meetings with law enforcement and DFACs often to discuss cases. DFACs, of course, if there's a child involved. And then there are the hospitals or the clinics. And then we have the victim advocates and the sexual assault nurse examiners that are trained specifically on sexual assault care. And then the prosecutors, whenever I have to go to court to testify, I work very closely with the district attorney, and the prosecutors are trained on the legal procedures and, of course, evidence preservation. And together, we can hopefully bring about a greater justice for our victims. So I keep mentioning trauma-informed care. So where do we start? And how do we get our community involved to give trauma-informed care? I went way back to where did we first start talking about trauma-informed care? And the American Association of Colleges of Nursing called for all nursing curricula to address the scope and nature of violence and how to care for patients. Well, I started to reevaluate. Well, I'm a professor, assistant professor, and I wondered, like, how well are we meeting this charge from the AACN? So that's something that I would like to look at to make sure that before nurses are put out into the field, that they're trained to take care of patients with violence. We need more sexual assault nurse examiners. We have to have funding for that. And to get these sexual assault nurse examiners out in our community and caring for our patients. Not only do we need sexual assault nurse examiners in clinics, but we also need them in our hospitals as well, and any place where people can show up for care. Again, I mentioned it's an intensive specific training for sexual assault nurse examiners, but also thought, what about training for all other nurses and our healthcare workers? And what about our community? I think that Georgia's doing a pretty good job, because not only are we getting the word out about sexual assault, we're also getting the word out about sex trafficking. And there are several sex trafficking modules that can be educational purposes for us as Georgians to watch. And it's very informative. And I think everybody in the state needs to take those that training module with about sexual assault and sex trafficking. Okay, so sexual assault nurse examiner, what is our role in trauma-informed care? We start off by introducing ourselves to the patient and understanding why the patient is there. And sometimes I refer to the person as a patient instead of a victim, because I don't want them to be labeled in my brain as victimized constantly. I want to see them as patients that are coming to the clinic for care. Before we do anything with our patients, we get consent. So nothing is done with our patients unless they consent first. We give a good supportive caring approach. Sometimes when I have a patient that I'm assessing, I'll put my pen down, I will turn away from the computer, and I will face the patient, and I will just say, tell me the reason why you're here, and I will listen. I give my attention fully to that patient, hearing everything. A patient is going to sit there feeling heard. I certainly hope the patient's feeling heard because I'm listening. We want to have relationship-centered communication, and again, that's active listening and asking the patient open-ended questions. Tell me more about that. And allowing the patient in their own words to tell you what happened. We want to have empathy. We're going to express it. We're not just going to have empathy. We're expressing the empathy. We express the empathy. I'm sorry that happened to you. You did the right thing by coming here. We have all kinds of resources for you. It can be a little bit overwhelming. We're courteous. We're respectful. And again, I keep going back to the patients that afterwards are like, can I get a hug? They really feel heard, and we're doing something wonderful for our patients at these clinics. We are actually making sure that they are getting their recovery from the very beginning. So we're working together on a plan. I work with the patient. I tell the patient, if I do anything that you feel like that's going to be uncomfortable or you want me to stop at any time, this is totally up to you. Let's make a plan. Let's decide how we're going to get this accomplished. And I have the patient completely involved in the whole care. I know I've read a couple of books, I've read articles, I've talked to people who were sexually assaulted, and sometimes it feels like they have horror stories about going to a clinic, and I want that changed. I don't want any patient to feel like they went to a sexual assault clinic and had a horror situation. That hug at the end, if they want that, lets me know that they felt safe and heard, and that's so important. We also offer strangulation care, so if there was a possibility that strangulation occurred, we're very specific about making sure they get cared for. We have sexually transmitted infection prophylaxis that we offer, and that's evidence-based. We give what the CDC says. We give evidence-based prophylactic medication, and we offer this to the patient free. The patient does not have to pay for anything at a clinic. And imagine if we charged a fee for patients to come to a sexual assault clinic, how greater the non-reporting would be. We, as sexual assault nurse examiners, have knowledge of sex trafficking. We understand sex trafficking. We understand how to recognize it. And then we do trauma-free assessment on our patients. If it's a pelvic exam, if it's taking pictures, if it's whatever we're doing for our patient, I'm constantly communicating with the patient to make sure the patient is consenting and okay with everything I do, and not re-traumatizing the patient whatsoever. So if I at all get a sense that the patient is starting to feel traumatized, I will stop the examination and talk to the patient and say, let's just stop this for right now, or whatever I need to do to make that patient feel safe. That's great that the sexual assault nurse examiners are giving great trauma-informed care, but how can we let this bleed over into our community and beyond the SART team? We have members of our community that are key players in this care that we give our patients. Law enforcement, we discussed, is one of them. And we need to have trained advocates and SANEs. We have specialized people in our clinics that give interviews to patients and ask patients interview questions that in a way that is more less traumatizing, and they're trained to be able to speak with a patient and gain information without negative impact. We need all of our healthcare workers to be trained. We need to make sure that every patient that we see gets appropriate referral network started so that they can take advantage of all the resources that Georgia has to offer. So just to feed off of that just a little bit, I wanted to make sure that everyone that's watching this is clear of what trauma-informed care is. And I mentioned that it's compassionate care. It's the way we make patients ease into getting help after a sexual assault and not re-traumatizing our patients. Primarily, we want our patients to feel safe. So whatever it takes for our patients to feel safe, we do that. We have a safe environment. A lot of times, most of the time when our patient is there in the rooms with us getting examination, there's law enforcement in the lobby. We're safe. We want trust. We want to build trust with our patients. We want to let the patient know, hey, I'm here for you. My goal is to give you care and to be your advocate. And choice. We want to make sure that our patients know that they have a choice. If you don't want to be here, you don't have to be here. If you don't want the medications, you don't have to take the medications. If you don't want the pelvic exam, you don't have to have that. So let's talk about what you want to have and what you're willing to do here to remain safe and to build trust. We're going to collaborate with that patient so that we can get a good plan of care. We're empowering that patient to make sure the patient knows that they're in control. We're there to help them. They are in control of that whole environment. We want to develop healing relationships. I've had patients call me on my cell phone afterwards to ask some questions that maybe they were just so anxious when everything was happening that they didn't really absorb the discharge information well. And so I'm always very thankful when I have the opportunity to talk to a patient, even after several days, so that I can ask, how are you doing? You know, are you holding up okay? Is there anything I can do to help? Another key factor of trauma-informed care is to understand that everyone's from a different culture. And that doesn't necessarily mean LGBTQ plus community, but it includes that. Not everybody looks like me. Not everybody acts like me. Not everybody looks like you. Everyone's different. We come to the table with a different culture, with a different background, and we understand that and appreciate that. And we want to support that. We want to make sure that they gain knowledge and education so that we're giving them facts and education about what they're experiencing and maybe about what's normal. It's okay that you're crying. This is completely normal. You know, make sure that the patient feels like they're not an oddity and they're not, you know, maybe that'll decrease their shame a little bit. We also want to keep our staff, the well-being of our staff, very good, because the way we handle ourselves, the way we are with them, they're going to mirror that. So if we're healthy and we're stable and we're safe for them, they're going to mirror that. So it's important that we as staff in our clinics, we also practice well-being. Okay, I had to bring social media in on here. I believe that social media reaches a lot of people. And when you're thinking about those 72% that don't report, you know, a lot of those individuals are on social media. So what we can do is, according to the CJCC, we can use social media to influence their thought process about sexual assault by information out there. I even have, I'm on TikTok, and I even have a TikTok account as a sexual assault nurse examiner, and I give my account name to patients sometimes if I feel like they're receptive to that and that's appropriate, and they can actually gain information from what I have to say on this TikTok. It's very minor, but it is information that is important. On TikTok and on other social media, we can publicize information. Facebook, we can have Facebook pages. We can talk about programs. We can talk about community events and inform our community about sexual assault and how to get care and how to deal with it. We can highlight public safety issues. We give reactive source for crime victims and advocates. So if you know someone that's been in a sexual assault situation, you could call this number, or you can talk to this person, or I would be happy to hear from you. There's an inviting social media out there for sexual assault victims. And we can also help victims who choose to tell their story. We can do that in a safe place. And we can make sure that it's a safe place for them to tell their story without a negative backlash or negativity. And we can also help with promoting their recovery through that. And I just wanted to put some personal pictures in here. I took this picture to let you know what is a sexual assault kit. We talked about the kit, we talked about evidence, we talked about assessment. And so what is that? So the kit comes with a dozen Q-tips in there. And when we collect swabs, we're collecting for touch DNA and saliva DNA, semen DNA, and we can collect it from various parts of the body. So we have envelopes that have specific names on there, such as the rectum or oral cavity. But then we also have envelopes that say other body area, and you can write in. So if a patient has a suction mark on their neck and we want to swab that for saliva, we can write, right side of neck on there. We also, sometimes we collect their pubic hair or a head hair or any foreign pubic hairs. And all of this is put into an envelope, and the process that it goes through is very strict. The handoff process is extremely strict, and we have a computerized, systematic way that we keep up with the kits, and we follow them as they make their way to the GBI. And we give the patients a login name and password, a login number and password, where they can actually go into this sexual assault kit tracking system, and they can see if their kit actually made it to the GBI. And I think this is important. What are we doing? We're allowing the patient to collaborate with us and be an active person in the process. Now, they can't get any results from the site, but they can follow their kit as it goes through the system. Also, we have a camera that's a secure digital forensic camera, SDFI, and it is a high quality camera that we take pictures of injuries. That may be anything from related to the sexual assault and battery or whatever, and maybe it's not related. An example of that would be, I had a patient the other day that had a cutting problem. So that person would cut her wrists from time to time. And she had some scars on both of her arms. And I took pictures of those, but that was only with her permission. All pictures that we take of the patient are with her permission. And I try not to take pictures of the face unless there's an injury there. So, and I tell the patient that these pictures are not going to be displayed in a courtroom. These are for me to identify any abnormalities, any injuries, and to make sure that she's safe. The pictures that are gained from these cameras they go through a very strict lockdown process. So they are not exposed to the public in any way. We also have the option to do drug screening. If maybe they had a drug-induced situation, or an alcoholic-induced situation prior to the sexual assault, so we can draw their blood, we can get urine samples, and we, again, do this all with the patient's permission and consent. This is an interesting part of the exam. We have black lights, we call them Woods lamps, where we can put the room to a dark environment, and we turn these lights on, and we have to have our special glasses on, and we can identify sometimes semen, saliva, foreign material on our patient that we can collect as evidence. And usually I'll let the patient wear some glasses, and I'll let them see as well. Sometimes their fingernails glow, and there are different ways that they can see different things on their body. Active part of the whole assessment process. So how do we close the gap from just standardized care for our patients as opposed to trauma-informed care? And I think, to sum it up, we need didactic, which means book learning, training for our students, not just nursing students, techs, advocates, medical students. All of them need to be trained on trauma-informed care. There have been some studies done on trauma-informed care educational modules and what's appropriate and what should be included with these nursing programs. And it's super interesting. All hospital and healthcare employees should take modules training on trauma-informed care, sexual assault, and sex trafficking. We need more community awareness and information, and we certainly can use social media to help us get there. We definitely want the funding to still come in so we can get our SANEs trained, we can get the resources that our patients need. Our patients don't have to pay for care at the clinic, so the funding is super important. And we want to continue the research. And the reason we want to continue the research is so that we are constantly informed about what our community looks like, where are our needs in our community, and what can we do differently in our community. And I just included a few major sites. If anyone watching this wants to get involved to help combat sexual assault or help with sexual assault victims and recovery, you can contact a number of different organizations in Georgia. And I'm sure that they're very happy to have you be a part of their organization, as that's a great way to grow our community as an informed community, is through organizations. And these are my references. And that concludes my presentation.